for inviting me to be here. It's an absolute pleasure and honor to be back here in Antalya after my last visit 8 years ago. So the talk I was asked to give is it time for surgical coronary revascularization to be a subspecialty? And if so, how do you do it? So if you were playing tennis and you tore your anterior cruciate ligament, who would you go to get it fixed? Would you go to a general orthopedic surgeon that does everything? Would you go to a knee specialist? Or would you go to the busiest knee specialist that you could find in your city? And I submit that it's C. So why should it be any different in cardiac surgery? If you look at the field of orthopedics, there's hand specialists, shoulder specialists, elbow specialists, hip specialists, knee specialists, pediatrics, foot and ankle specialists, spine specialists, oncology specialists, trauma specialists, sports medicine. I think there's even a left little toe specialist in orthopedics. What do we have in thoracic surgery? Well, we have aortic valve specialists. We have mitral valve specialists that take great pride in their ability to perform a mitral valve through minimally invasive or robotic approaches. We have thoracic oncologists, foregut specialists, congenital heart surgeons, now adult congenital heart surgeons, thoracic aortic specialists, heart failure specialists that specialize in transplant mechanical circulatory support. We now have structural heart specialists, and we have arrhythmia specialists. But why don't we have a coronary revascularization specialist? Well, if we look, it's the most common operation we still do in cardiac surgery. Last year, there were 160,000 coronary bypass operations done in the United States. That has actually increased over the last 10 years. It's not going away despite PCI. So this is an editorial that myself and Professor Taggart from Oxford wrote that was published in the Journal of Thoracic and Cardiovascular Surgery in November, entitled Coronary Revascularization Should Be a Subspecialty Focus in Cardiac Surgery, with this quote from the German sociologist and philosopher Max Weber: "A really definitive and good accomplishment is today always a specialized accomplishment." And I do think that applies to coronary revascularization. So if we look at our subspecialties in cardiac surgery, this is a diagram from that editorial. We have our mitral and tricuspid valve specialists. We have our aortic valve specialists. We have our thoracic aortic specialists. We have our transplant and mechanical circulatory support specialists. We have adult congenital. We have arrhythmia specialists. But again, what's missing is our coronary artery surgery specialists. Where are they? All surgeons that specialize in these other areas take great pride in what they do. But nobody brags about or takes pride in being a coronary artery surgeon. And I think that's a major mistake in our specialty. After all, what is the most technically demanding operation that we do in cardiac surgery? Is it aortic valve replacement? Is it mitral valve repair? No, it's coronary artery bypass grafting. It's the most technically demanding operation that we do in cardiac surgery, and I would challenge anyone to say otherwise. So where are our specialists that focus just on coronary revascularization? So let me ask a question. CABG mortality is increasing over the years, decreasing over the years, or staying the same? Anybody want to hazard a guess? It's actually increasing. This is the STS database over the last 10 years, and the cardiac surgery or coronary bypass mortality has actually increased over the last 10 years. which is kind of sobering. If we look at coronary revascularization in the United States, we have 1,150 cardiac surgery programs, 2,676 cardiac surgeons. We perform 160 bypass operations a year. That averages out to 139 CABG procedures per year, or 3 per week, or it averages to 59 CABGs per surgeon per year, or 1 a week. Now, I don't care what you do in life, whether it's cardiac surgery, whether it's PCI, or whether it's playing tennis. If you only do it once a week, I don't think you're going to be very good at it. And I think that's reflected in the current state of coronary revascularization in the United States. Off-pump CABG constitutes 15% of all coronary revascularization. And that's even a false number, because there's many centers like John Puskis in New York that do everything off-pump, and Emory in Atlanta that do everything off-pump, and other centers that do virtually none. Despite the known clear benefits of multiple arterial grafting, bilateral internal mammary artery use in the U.S. stays stubbornly fixed at 5%. And intraoperative graft flow measurement, which has clearly been shown to increase graft patency, is 17% in the United States. In Japan, it's 80%. In the Nordic countries, it's 80%. In Germany, it's 70%. And I would maintain that if we had specialists that focused in coronary surgery, that took pride in what they do, this is what they did day in and day out, that these numbers would all improve. Now, it's been well known for many years that there is a volume outcome relationship, especially for high-risk surgery. And what that says is the more you do, the better your outcomes are. So this was the original study back in the early 2000s that looked at Medicare outcomes in the United States by hospital volume. And if you had hospitals that did over 850 coronary bypass operations a year, the mortality was lowest, and the mortality was highest in the low-volume hospitals. And that's true for surgeon also. So the lowest volume surgeons had a mortality that was 33% higher than the high-volume surgeons. So how to do this? Well, the idea is to have advanced centers of care. And the premise behind this is that there is a volume outcome relationship in medical procedures, and the more complex the procedure, the greater that relationship. And I would argue that coronary artery bypass surgery is the most complex operation that we do. And the relationship is not only about the performance of the procedure, it's about the whole healthcare ecosystem, the diagnostic expertise, the patient selection, and the post-procedure care. Now, not everybody can go to one or two, or not everybody can go to the Cleveland Clinic or the Mayo Clinic to get their care done, so all this has to be balanced against access to care. And the same is true in Turkey. So this is the 2014 ESC-EACTS guidelines on myocardial revascularization, and a Class 1 level of evidence B recommendation is to perform revascularization in a hospital structure and by a team specialized in cardiac surgery using written protocols. So the idea here is a tiered system of coronary revascularization centers. They have to have commitment to structure, processes, and outcomes. And it's not just about performing a procedure, but a comprehensive approach to treating a disease. So this would be inclusive and not exclusive to set aspirational goals for all centers. There would be accreditation for it, and centers would have to do a minimum number of CABG procedures and a minimum number of PCI procedures, because the interventional cardiology expertise needs to be commensurate with the surgical expertise. And there's a commitment to a heart team approach, shared decision-making, guideline adherence, public reporting of outcomes, participation in research trials, and training and education. To establish best practices in surgical coronary revascularization, which includes off-pump CABG, multiple arterial revascularization, intraoperative graft flow assessment, and robotic TCOB as part of hybrid revascularization. Just as important is that there be best practices in PCI, including routine use of FFR and IFR, intermediate lesions, multi-vessel stenting for high-risk patients, high-risk left main stenting rather than surgery, supported PCI, and treatment of chronic total occlusions. This can't be one or the other. This has to go hand in hand. And indeed, using this approach, which we adopted in our center 2 years ago, we did 563 coronary bypass operations last year with no mortality. It can be done. Now, the price that got paid for that is that our mortality in PCI went up because of the fact that some of the higher risk patients were treated by PCI rather than surgery. But it was a heart team approach. So the idea is to optimize the care of the patient with coronary disease. Increasing complexities of diagnosis and therapy require increasing levels of experience and expertise. There has to be an institutional commitment, a heart team approach, and shared decision-making with the patient. So the idea here is a rising tide floats all boats. And if we took the same pride in coronary bypass surgery, which is the most common operation that we do in heart transplant, that we do in mitral valve repair, that I submit that our coronary revascularization outcomes would improve. Thank you very much.